Ms. Farnitano for coming in tonight and taking the time to join us for our board meeting. I figured this would be a good time for the doctor to be able to give a little summary of where we're at with our community, maybe a little bit on the new information regarding vaccines, and then have a little time for some questions and answers on behalf of our board. And then I also fielded some questions from our students, staff, and parents. Dr. Farnitano, thank you for joining us.
You're welcome. Happy to be here. Yeah, I did get your questions, and so I'll try to address as many of them as possible. First, just kind of give a little overview of where we're at and the situation. I don't have that much good news to offer. We were really concerned heading into the Thanksgiving holiday about the increasing case rates and increasing hospital numbers, and things seemed to stabilize a little bit for that week before Thanksgiving. But we've been seeing happening since Thanksgiving is even more alarming. So our case rates are higher than they've ever been, higher than they were in the spring or the summer. Our test positivity rate is higher than it's ever been, higher than the spring or the summer. And most concerning is our hospitalization rates for people hospitalized with COVID-19 are higher than they have ever been. We hit a peak of 110 patients in area hospitals due to COVID in the summer. Yesterday we were at 150. Today we're at 160, and every day the number goes up. And so, because of these alarming numbers, several Bay Area health officers took the action last week to institute the state's regional stay-at-home order, even though we were only at 25% regional ICU capacity at the time, and the trigger the state's using for that capacity is 15%. Well, now the Bay Area is 20%, and the Sacramento region has now joined the San Joaquin Valley and Southern California regions as falling below that 15% trigger. In fact, the San Joaquin Valley is about 5 or 6%. And our neighbor county, San Joaquin County, their ICUs are over capacity. They're having to treat ICU patients in make-do ICU rooms, converting other rooms into ICU rooms. They've got the hospital in French Camp is 13% over their ICU capacity, and the hospital in Stockton's 23%. We know that the changes, such as stay-at-home orders, if they're effective, we can see it takes about 2 or 3 weeks before it really starts to affect the hospital numbers, because it usually takes about a week or so before someone gets exposed, they start getting sick, and then another week before they get sick enough that they wind up in the hospital. So we still haven't seen whether the effects of the stay-at-home order at this time, but we're hoping that it'll be effective to flatten this curve one final time and get us through this concerning crunch. And that what's concerning is that it's peaking all across the state, and so if our hospitals fill up, we won't have hospitals in other regions to transfer patients to. Now, part of the stay-at-home order, was designed really to not close schools that were already open, because I know the schools have worked really hard to get open, and we haven't seen a lot of transmission in schools. We don't see schools really driving community transmission. We have had some cases at schools that are open and even outbreaks, but they've been very few and far between, fortunately, to this point. So, we have allowed schools that have already been open to continue to be open if they choose to. But I think, some schools are continuing to do that. Some schools are electing to suspend in-person education, at least until the new year. just as far as Knights and district and areas is concerned, you're really kind of surrounded by communities that have even higher rates of COVID than the general population. So our for example, Byron has a case rate in the last 2 weeks that's about twice as high as the county as a whole. We've got Discovery Bay, which is about 50% higher than the county as a whole, and Antioch and Brentwood are also about 20% higher than the county as a whole. So you're definitely surrounded by communities with very high levels of transmission going on. Just to kind of address some of the questions that were sent to me. So CDC did come out with new quarantine guidance, and the state health department, Department of Public Health, has reviewed those, and they've issued their guidelines, which are similar. And we're adopting the state's guidelines. The state's guidelines essentially say 10 days quarantine, whether or not you have a test. The CDC's guideline provides an option that if you get a test between days 5 and 7, you could end your quarantine after 7 days. But the state felt it was more prudent to stick with 10 days, encourage a test but not require a test. So our local health order is going to be amended. We have a local quarantine order that requires people to quarantine after an exposure, and it's going to stay with the 10-day limit. That is shorter than the 14-day, and that's because there's still a risk with that shorter quarantine. There's about a 1% chance you might miss somebody who actually did catch COVID and becomes infectious after they leave that quarantine. So it's erring on the side of safety there. But it does get easier to comply with than a 14-day quarantine. So there were some questions kind of specific around schools. So if someone does test positive for COVID-19 and recovers, do they have to be quarantined again if they're considered a close contact? So if someone with a lab-proven COVID test, we don't really consider them to be able to catch COVID-19 for at least 3 months, and that's the evidence seems to show that it's extremely rare to get reinfected with COVID-19 within 3 months of an infection. So during that 3-month time period, they don't need to quarantine if they got re-exposed. They don't need to retest. In fact, we recommend against retesting because it can be confusing to interpret the results. But then if it was after 3 months, then you'd be kind of treated as someone who never had COVID as far as your risk of getting infected again and needing to quarantine. Now, if a student's household member has COVID-19, the child then would be required to quarantine. And if the child is living in that house while the household member has quarantine, the child's quarantine doesn't really start until after that household member is non-infectious. So, for example, say if the parent got COVID and their symptoms started on the 1st of December, they have to isolate for 10 days after that. And so they would have to isolate until December 10th. If the child was in the household at that time, they're being continually exposed all the way through December 10th. So their quarantine period would be 14 days after the 10th. So they'd have to quarantine until December 24th. So yeah, the quarantine doesn't really start until this exposure to the patient with COVID stops. Now, if a child, was found to be positive for COVID and they attended class during their infectious period, which usually starts 2 days before their symptoms start or 2 days before their test, if they had a a test but no symptoms, then that's when our case investigation team would work with the school staff. In many cases, the entire classroom would need to be closed and quarantined, but it's a very case-by-case basis. Really trying to figure out can we determine with good confidence who was really exposed within 6 feet for 15 minutes or more during the time the child was at school. Many times, we can't really figure that out with certainty. So to be on the safe side, the entire classroom needs to be quarantined. But sometimes, you can have fair confidence that you could exclude certain parts of that classroom. So it's really a case-by-case basis, and our case investigation team, works with schools to work through these situations. Now, children don't have any guaranteed protection from COVID. We do know young children, especially smaller children, elementary school children, tend to get COVID less. All children don't tend to get as severe disease. Their risk for being hospitalized or dying from COVID is much less than adults, although there have been deaths in kids and teenagers, and there have been long-term consequences like some of these neurologic syndromes and blood clotting syndromes, but they're very rare. Some of it, there may be some biological factors. There's some receptors in the lungs that are not really developed in young kids that the virus uses to enter lungs. Some of it is just because they're smaller lung volumes, so their breath doesn't travel as far as them passing virus from them to other people. So they may pass virus less to other people, but they can still pass virus. Some because their height and they're not standing at the same mouth and nose level as another adult. They may be not getting as close to someone who's breathing and contagious and breathing out COVID-19. So there may be some sort of physical factors and biological factors, but it's all relative. So kids can get COVID, they can pass COVID, they can catch COVID, they can get very sick with COVID. It's just less than teens and adults. As far as our testing, we still are, in our county test sites, we're still getting turnaround times for results are 1 to 2 days. There's been some labs that have been taking 3 or 4 days to get lab results. Some of the Kaiser labs have been taking a little bit longer. It's not nearly as bad as the backup we had in the middle of the summer, where sometimes it was taking a week or two. I'm not hearing reports of that. The real outliers are maybe 4 or 5 days that I've been hearing, but most of them are 1 to 3 days. We do have a big demand. We've had it ever since the Thanksgiving week, 4 appointments, and we've been trying to add more testing sites and testing dates. Our weekend appointments are really in biggest demand, so we're trying to add more weekend appointments. I looked earlier today. You could get an appointment tomorrow in Martinez, and you could get appointments this coming Monday in both East County and West County, and then the rest of the week there was lots of appointments. So sometimes you can't always find an appointment the same day, although we are releasing some. We hold back some same-day appointments every morning. So when people check in the morning, they can usually get a same-day appointment before they all fill up. But we are trying to add more testing capacity because the demand has been higher than ever. And then, can people who can't socially distance outside of the home because of work, is it recommended to wear a mask inside the house once you get home? I mean, it's something that actually you could consider if you feel like you're getting exposed because of work or something else outside the home, and you have vulnerable family members in your home. Even considering masking inside the house for the ultimate protection. We know that once somebody in a household gets COVID, it's very hard to keep it from spreading to other household members. So if someone does test positive for COVID, we really recommend they isolate outside of the home. We have hotel rooms that the county can provide for people to finish their isolation period so they don't expose family members. People are very reluctant to take us up on that for multiple reasons, but we do have those available. If you did have COVID and you're going to try to recuperate inside your home with other people, we would recommend at that point that everybody in the household wear masks to help reduce the risk that it spreads within the household. And so that comes to when in-person school does start, should students stay away from their grandparents? My elderly in-laws are, they have been sheltering alone, and I've been trying to avoid visits to them. I haven't seen them in months, actually. I think even though school doesn't seem to be as high a risk as some other business settings, and certainly not as high risk as restaurants and other indoor settings, there is some risk there. And if those grandparents were, frail and elderly, it might be best for them to stay away from their grandchildren for a while. Vaccines coming, and it might be best to play it safe for a few more months. So how easily is this virus spread on surfaces, paper documents? We don't really have any clear proven spread of COVID on surfaces. Probably the most important thing to be concerned about is frequently touched surfaces like doorknobs. But the thing to do there is just use your hand sanitizer every time you touch a doorknob or a high traffic surface. Paper, the virus doesn't really survive very long on paper or hard surfaces, really just a few hours at the most. So, good hand hygiene is probably the most important thing, rather than trying to disinfect the actual documents or other kind of things. We know the virus spreads most easily through respiratory droplets, and those can spread up to 6 feet with talking, with yelling or singing. They can travel 9 or 10 feet. The virus can also spread through very fine particles called aerosols, but it's much, much more difficult to spread that way. The cases where we've seen that have been in very, very crowded indoor settings where there's a lot of people crammed close together and there's not port air movement. So, what's really recommended to reduce the risk of that is just lots of air circulation, having the ventilator systems, really pulling a lot of outdoor air, open up windows, get a lot of fresh air in. It's that stagnant air that's just sitting there and collecting virus over time that's the most concern. Again, disinfection of surfaces is less important. It's really the air is how this virus is spread. And then these different sort of enclosures, sneeze guards, plexiglass barriers. We don't really have a lot of evidence about how effective they are. I mean, certainly if somebody's sneezing right on one and you're like really close to somebody, it may be helpful. But if you're already 6 feet apart, adding an enclosure, the virus is going to travel above it and across and around it, and then you get into that kind of aerosol transmission, and then there it's where more the ventilation is more important. So we talk about 4 to 6 feet limits, and we're really talking. We've tried to emphasize that means sort of 6 feet nose to nose for the kids to be apart. We realize, the desks might be as close as 4 feet apart, but that's really 6 feet nose to nose from where the kids are sitting. And we don't have enough evidence to say that you can put some barriers around the kids and move them closer and still be as safe. So they can add things, but they don't really replace the need to keep the kids and the teachers 6 feet apart. So how long do I think this stay-at-home order will last? I'm really hopeful that if the community really embraces this, we've seen that in 2 to 3 weeks, these kind of measures, if they're really followed by a large part of the population, can really make a difference. We saw that in the spring and we saw that in the summer. So we will know, we're not even a week into it now, we will know, by Christmas week, whether this is really taking an effect. And once we can see that, we're past the peak of hospitalizations, or at least our projections show we're not going to run out of ICU rooms, then we can start breathing a sigh of relief and start opening things up. So, I like to see an earlier signal, but it may not be till Christmas week before we really see whether this is working or not. Unfortunately, we're running out of options. We've closed down almost everything we can close down. If this doesn't work, it's going to be really, really a big problem. Now, question about how long do antibodies last if you get a COVID infection? They can. We don't really know how long they last. We know they can last for several months. There's some reason to think that a natural infection will not protect you as well as a vaccine. Vaccines are really designed to promote long-term infection, even longer than a natural infection, or long-term protection. And there's lots of different antibody tests, and they're all over the place, and some are good and some are not good. And so some can detect antibody for a month or two, and some can detect them for longer. I think if someone has COVID, getting an antibody test isn't really that helpful. If you weren't sure if you had COVID and you had an antibody test, it kind of helps tell you that you had COVID, but it doesn't really tell you, whether you can get it again. And we think, again, after the first 3 months, you're probably protected, but we don't really know much about longer than 3 months. We certainly recommend people to still get the vaccine, even if they've had COVID. We don't know if you can we do know you can catch it again. There's some rare cases of catching COVID again. We don't know how often that is. But it could be like many other coronaviruses, including many common cold viruses, where you can catch them again and again. We also don't know how long these vaccines will provide protection. Will you need get a booster dose every year like the flu shot, or is it going to be more like measles, where you get 1 or 2 boosters and then you're good for life? It'll probably be a year before we know whether we need a booster dose every year or not. And then there was a question about plasma treatments for people with COVID. And there's 2 kinds of those. One is the initial one that they've been using for months, which was they took what they call convalescent plasma, so antibodies from people who had COVID, and they took them out of their blood and they concentrated them and they gave them to people in the hospital who were sick. And I talked to my hospital colleagues, and they're not sure that this stuff does anything. There's never been any really good trials on them, and we don't have really good data on them, but it's not really clear that they're doing much. It's something that's been given because we've been desperate and looking for some kind of treatment. The newer thing is these lab developed specific, what we call monoclonal antibodies, that are a pure strain of a specific antibody that targets the virus. And those, that includes one of the treatments Donald Trump received when he was hospitalized with COVID. And there's several products that have gotten emergency approval. The studies on those are very small, but they seem to work on people who have symptoms but aren't sick enough to need to be in the hospital. And they seem to maybe help keep people from getting sick enough to be in the hospital. There's no proof that they save lives, but they may save hospital beds and help keep people from getting sick enough to be in the hospital. And so we have some of those. We've distributed some of those to area hospitals, and we're working with some infusion centers to be able to give those to people who get positive for COVID. They have symptoms, and they have to be in one of the higher risk categories. They're older, or they have medical conditions like heart disease or diabetes. And if they qualify, they can get one of those infusions. Now, as far as the vaccines, the one that may be approved at the end of this week is the Pfizer vaccine, and the one right behind that's the Moderna vaccine that might be approved next week. They both need a booster shot at 3 or 4 weeks later. It doesn't have to be exactly 3 or 4 weeks later, but they have to be spaced at least that much apart. They can, like most vaccines, you can give it later, you just can't give it sooner. So we're hoping to get a very small supply of some of these vaccines in the next few weeks. So it'll be targeted at the highest risk healthcare workers, emergency room nurses working in intensive care units or in COVID wards. It'll be a few months before we'll be able to have enough that a large part of the general population will get them. We're also going to be prioritizing nursing home residents and people who live in long-term care facilities to get the first doses. No one's talking about requiring or mandating these vaccines. They're still, not fully approved. There's still a lot of unknowns, about them. There's still lots of people who want them. So there's no point of really making people who are cautious about them and wary about taking them to get them when there's lots of people who want them and we don't have them available for them yet. So it's really going to be a voluntary thing for people who want them. Hopefully enough people will have confidence in the vaccines that they'll take them. From what I've seen so far, I'm gonna take my vaccine once it's my turn to get the vaccine. So when exactly will educators expect vaccinations? Educators are considered essential workers. So essential workers are included in the second phase of the CDC's guidelines. The first phase is healthcare workers, first responders, and long-term care facility residents and staff. The second phase is essential workers and those higher risk individuals like the elderly and people with higher risk medical conditions. There's some debate about whether to prioritize teachers and educators in front of other essential workers. But right now, the guidelines just specify, essential workers. And then the third phase is sort of the rest of the population, healthier adults. And then this vaccine, we have no idea when it will be available for children. It hasn't really been studied in children. They're starting to do studies in children, but it'll be a long time before we have the safety data in children. Before it'll be approved or recommended for children. The studies on ibuprofen really haven't shown that ibuprofen is a risk. So there was some talk about that a while ago, but people looked into it and there's no real clear evidence that that's harmful. And then let's see. So, what's your advice for children and parents who are fearful about a return to school? I mean, I think it's a difficult choice. I mean, it's, we can't really talk about safe or non-safe. We're really talking about, less safe and more safe. And each, parent is going to make a judgment for their children about the benefits of in-person learning versus the risk of getting exposed to COVID, and that risk, the benefit's always there. To school, the risk really varies by how much community transmission is going on. So parents may have different levels of feel about that decision depending on what level of COVID is in the community. Another question is, should schools reopen if we are in purple? The current state guidelines say the schools that aren't already open can't open in purple unless they get an elementary school waiver. Those waivers are also not going to be granted unless if the case rate is more than twice the cutoff for purple, 7 cases per 100,000 per day. So in other words, if it's more than 14, we're now over 20. So we're not, our local health department's not going to be approving waivers until we drop below that level. And so for schools that haven't already gotten an approved waiver and haven't already opened. And then what advice would you give to parents about passive screening at home before returning to school? So I think the most important thing is symptom checks. Temperature checks don't catch a lot of adults and kids. They might catch more kids than adults, but it's the symptom screening that's most helpful in adults. And it's really with adults, the main symptoms: cough, shortness of breath, fever, fatigue. And one very specific one is a loss of taste or smell. For kids, especially young kids, diarrhea added to that as a common COVID symptom. So taking somebody's temperature for adults and older kids doesn't really add much to those symptoms because younger kids often don't, express their symptoms and tend to also mount fevers more commonly than older people. The temperature checking might be a little bit more useful in younger kids, but it's the symptoms. Is the child feeling well? Is the child acting well? Are they coughing? Have they lost their appetite? Are they having diarrhea? Those are the symptoms to keep a child away from school. Check with their doctor or get them tested for COVID before coming back to school. Two more left. Is it safer to cough in a reusable mask or move away from people, take off your mask, and then cough? Well, when you cough, the cough doesn't stay in the mask. Even in one of those N95 masks, if you cough, the bands stretch and the cough goes outside the mask. So it's really important to move away from people. Cough into your sleeve. But make sure you're at least 6 feet, if not farther away from people when you cough. And then one question: when can we return to real school without masks and distancing? And that's, it's like, when is real life, the life we had in 2019, going to return? And it may not be till next summer. It may be longer. We may be wearing masks and social distancing all the way through 2021. Most of the experts estimate that 70 to 80% of the population would have to get a COVID vaccine before there's enough herd immunity that and with some people hesitant about taking vaccines, it could be a long time before we get that much of the population to take a vaccine. We've made enough vaccine to go around. And how bad can this pandemic still get in our county? I don't know if anyone knows. I mean, I look back to New York, and I have a cousin who is in Brooklyn, and she told me every night she couldn't sleep because the sirens were going off every night as the ambulances were taking people to the hospitals. And I saw the pictures of the morgue trucks and the mass graves. I hate to think that kind of a scenario comes to our county, but every day I see the numbers going up and there's no sign of them slowing. So I just hope, everyone really takes this stay-at-home order to heart, and we can really, break the back of this new wave in the next few weeks. And people don't decide that they're just going to, gather for Christmas the way they do every single year, because that could be a very deadly decision. And then what's, the best way to ensure positive mental health for our students and staff? I mean, it's hard. It's really been hard on everybody. All this sheltering in place, lack of in-person social contacts. I mean, I think it's really been challenging for everyone, especially challenging for kids. And I think just trying to reach out to people, virtually, call people on the phone, do, virtual meetings and things, try to, be positive, try to encourage each other. But it's, and recognizing that it's really difficult, and that people are losing their jobs, they're losing their businesses. It's really, there's economic harm, there's social harm, there's mental stress over all the loneliness. It's really hard, but right now it's all about saving lives. So I think that's all the questions. And I'll, if there's anything else, any other questions you have.
Yeah, I'd like to open up to our board members. Those were the questions that we received from students and staff and families in the Knights. Board members, do you have any questions for Dr. Farnitano?
Her mic's on.
Your microphone?
Your mic.
We're not able to hear you.
Your mic.
Got it. Thank you. Okay. I've been taking notes, so just let's see. I don't want to ask one that you've already covered here. Okay. You were talking about the plasma treatment and also the infusion that the president had, and that that would be available to people with pre-existing conditions. I'm wondering why that wouldn't be available to everybody who chose to have that treatment if they were coming down with COVID, and because it is still possible that it could get bad quickly. And if that's not available to them, then, they could end up being a casualty. So I'm wondering why that's not available to all.
No, it's a great question. And ideally, it should be available to all, because even younger people, even though their risk of serious illness is much less, it's not zero. And we've seen cases of young adults, even teenagers and kids getting really sick and in the hospital, and sadly even a few deaths. There's extremely limited supplies of these antibodies, and so the FDA has directed that the supply they've actually purchased, the limited supply from the manufacturer, and they're distributing it to states, who are distributing it to local health departments, and we're distributing it to the local hospitals, that they've directed, because of such a limited supply, it only be used in these highest risk individuals. So it makes the maximum benefit of this very limited supply.
Okay. And if a person is hospitalized and is getting worse, would that put them in that category to where they would be able to be a candidate for it?
No, because the studies showed that the benefit was only found in people who weren't yet sick enough to be hospitalized. And there's really two phases of the COVID illness. The first phase is where the virus is running rampant, and treatments targeted against the virus, like these antibody treatments, seem to be beneficial. The second phase is where the body goes into this immune storm, this inflammatory storm, and there's all these inflammatory chemicals get released, and that causes damage to the lungs and damage to other parts of the body. And it's this inflammatory storm that's really the most deadly part of the infection. But that's the second phase, and it's medications like dexamethasone, which are given to hospitalized patients and have been shown to decrease the death rates. Those are where they target that inflammatory storm, and that's the kind of medicine that's helpful for people who are sick enough to already be in the hospital.
Mm-hmm. And another question I have is ICU beds. I've been hearing talk about how, the second wave, and it's how, has potential of being worse than the onset of COVID. And I'm wondering, have they been, the hospitals, is there anything in the works of having more beds available, maybe switching out units that maybe were for non-urgent to turn them into more of a COVID ward or an ICU? I don't understand why there's the same number of beds that there were pre-COVID that now are all filling up or are already full. Why was there not a plan in place, or is there a plan in place to get more available if we're expecting this wave, this storm of new cases?
There is actually a plan, and the hospitals that develop plans in the spring, what we call the surge plans, for different stages to convert other beds into intensive care unit beds, taking like operating rooms and turning them into intensive care units, taking post-operative recovery rooms and turning them into intensive care unit beds, taking emergency department rooms, turning them into intensive care unit beds. The surge plans in our hospitals, together they can double the number of intensive care unit beds and double the total number of regular hospital beds by converting offices into hospital rooms, converting old mothballed hospital wards into hospital rooms. And we went through in the spring and purchased a lot of ventilators. So we've doubled the supply of ventilators in our county so that we'd have enough ventilators to be able to operate these rooms. The concern is the staff to run those. And to run a ventilator, you need really highly trained nurses and highly trained respiratory therapists and staff and doctors. And in the spring and even in the summer, we could call upon staff from other states to help us out and get what they call traveling nurses or nurses from these staffing agencies to come from out of state and help us staff. But right now, with the COVID surging essentially in almost every single state in the country, we can't turn to those anymore. And so the concern is we'll have these extra beds, these converted beds, but we may not have the trained staff. And the hospitals are even preparing for that. So they're talking about taking their clinic nurses and giving them crash courses on how to run a ventilator. But I know if I was sick with COVID, or if I had a heart attack, or if I had a motor vehicle accident, and any of those things wound me up in the ICU, I'd like to be treated by a real ICU nurse and a real ICU doctor in a real ICU, rather than some converted bed with a primary care doctor and a clinic nurse trying to figure out how to do all this stuff. They're going to do the best they can, but it's still not ideal.
Mm-hmm. Okay, let's see. And the last question I have for you. The last I looked, when I went onto the county site, there was approximately 50% of our population in our county that had been tested. Is that's still the number? I'm just assuming it's roughly around that.
Roughly around that, yeah. And
the percentages, correct me if I'm wrong, so there's 50% of the population have been tested. And then when you have the positives and the percentages that are given, all the percentages, all the numbers when cases go up and whatnot, is it all based on that that 50% that have been tested and not total population. So when, let's just say, 100 people were tested and, 25 were positive. So we're getting a 25% positive rate. But there's a whole nother, 50% of the population out there. So in my mind, it makes the percentage look higher than if we're just basing it all on total population and not just total tested. And so I'm wondering about that. And then also, let's see. Yeah, well, how what are your thoughts to that? I mean, how are we when, someone who's hearing these numbers at home, whether it's on the news or if you're looking at the website, the numbers look scary, but then when you take under the total population, they're really not as bad as the graphs and the charts we're looking at, because they're only based on those who have been tested.
Yeah, and so good points. So right now, our dashboard shows that 670,000 tests have been done. Now, some people have tested multiple times. We're asking our nursing home staff to test every month, healthcare workers to test every month. I myself get tested every month because I work in clinic and get exposed to patients. So that's 670,000 tests, but it's probably maybe half the population has taken a test at least once, and half the population, we have 1.1 million people in our county, half of our county has never ever taken a test. I'd like to see it much higher than that. But when we talk about the test positivity rate, it is the positivity rate of tests. So on a given day, again, if there were 100 tests and 25 were positive, that's a 25% positivity rate of the tests. We know, the experts tell us that, less than 3%, you're doing pretty good. Above 8%, things are really out of control, and we're at that, around that 8% level now. We also, most of the experts say that, for every person who tests positive, there's probably 5 other people out there in the community who didn't get a test, who are positive. And we know about 40% of people are asymptomatic. And we know there's also other people who had mild symptoms who just never came in, for a test. So another way to look at that is, people are usually, contagious for, 10 to 14 days when they get infected with COVID. And if you look at, let me just quickly pull up the number. Right now, we've got about 4,400 people that we know of who have an active infection walking around the county. So you can multiply that by 5, that means there's probably about 20,000 people right now in Contra Costa County who have an infection. Most of them don't know they have it. They haven't had a test. So there's the majority of those 20,000 people may be, still getting together with friends, still going to the grocery store and other things with COVID, and they may be, spreading it to others without knowing it.
Are the tests, are they still is there still issues with false positives, and what percentage of false positives are there? And so what so
the standard test we use is a PCR test. It's a test for DNA of the virus. It's a very specific test. The false positive rates for most of the tests is somewhere around 1%. false negatives are more common. So, and it all depends on how good of a swab is taken. But, false negatives can be as much as 5 or 10%. So you're more likely to miss a case and get a negative test than you are to have a positive test that's not a true infection. Now, there's also these new, more rapid tests. They're called antigen tests. They test for proteins of the virus. They're not as sensitive for picking up virus, so they can miss up to 20% or even 30% of cases. But they're also very specific. If they're really a well-trained person doing them and reading them, their false positives are also 1 or 2%. But we've seen sometimes they're because they're being run in outside of labs, and some of them are just like a card that you put a swab on, you add a couple of drops of reagent, you look for a color change. It's almost like a pregnancy test, but it's just a little more complicated to do it just the right way and read it the right way. So we have seen some cases where someone's reading it, the card really says negative, but they're reading it as positive. So we do get a few, false positives from those rapid tests. And that's part of the reason why most of the time we recommend on those rapid tests, if you do get a positive, we double check it with the other test just to be sure.
Is the rapid test also a nasal swab?
It is a nasal swab as well. Yeah. And it's only because it's not as, as sensitive. It's only recommended to use in people in their first 5 or 10 days of symptoms, not for people without symptoms and not people who've had symptoms for more than 10 days. So using it during that time when there's the most virus, when it's most likely to be an accurate test.
Okay, thank you.
I have a question that's submitted by a friend to me. If you have underlying health conditions, how do you make yourself eligible for the earlier stages of the vaccine? Would that be something that would be through your primary care physician could recommend you, or what avenue you take?
A lot of that's still really being worked out. The CDC at the federal level is still revising their guidelines about, which conditions should be prioritized, and then the states kind of reviewing those. Right now it's a little easier because we're focusing on where people live or work. So you live in a nursing home or you work in a hospital. But once it comes down to the general population and we're trying to prioritize, one of the things we'll prioritize is people by age, people over 65, probably after that, people over 50. But then by the conditions, we haven't sort of figured out how we identify people with those conditions. Once it's in medical offices and widely available, it'll be, easier for your, go to your doctor, and your doctor knows what your medical conditions are and can get you the vaccine. But that intermediate step, when we might be setting up, big drive-through vaccine clinics or other things, trying to figure out how to identify, those groups, we're still kind of working out the details on that.
Do you have any more questions for Dr. Farnitano?
Harvey, I can barely hear you.
Do we have any more questions for Dr. Farnitano?
I have one quick question. When they talk about a person, if one person gets it in a household, they should isolate. My question is how I know with most things, before symptoms actually show you're contagious. Mm-hmm. I'm curious how effective that has been with one person. I have a large family, and usually if one person gets something, it's going to go through everybody. I really wonder how effective isolation has been in, households.
Yeah, and it's a good point. And we know that like the 2 days before someone develops symptoms, especially the 24 hours before symptoms develop, is really the most contagious period. And so, isolating, trying to isolate within the family is rarely successful. And then many times, even if someone isolates, they get a positive test and they go into a motel room, it's already too late that the family's already been exposed. So unfortunately, it's really hard to prevent this from spreading within a family.
That's what I figured.
I just want to let everybody know that board member Veldaki, he's a firefighter. He had to leave on a call. That's why he's Any other final questions for Dr. Farnitano?
No.
Dr. Farnitano, I want to thank you again for your time and joining us for the Knightston School District. We are a small district out here in the Far East County, so we appreciate you being able to show up and share your knowledge with us. And I want to thank you for your leadership, and I want to thank you for keeping a clear message out there. And really cool seeing you on the news every night and seeing you here as part of our board meeting. So, we appreciate it.
Well, thank you. I'm happy to be here, and all of you be very safe.
Thank you.
Thank you. Have a good evening.
Thank you very much.